all for the third session of this Indo-Korea joint webinar on advances in biosensors. This talk will be given by Professor Uma Maheswari from Shastra Deemed University, and she will be talking on biosensors for metabolic syndrome. And I'm extremely happy to introduce my colleague and my collaborator, Professor Uma. So she is a professor and a dean in the School of Arts and Science Humanities and Center for Nanoscience and Nanotechnology and Advanced Biomaterials at Shastra University. She is also a visiting professor to University of Bordeaux, France, and honorary professor at Deakin University, Australia. And she completed her master's in applied chemistry from PSG College of Technology, affiliated to Barodia University, in the year 2000. She did her postdoctoral research in electrophysiology at the University of Texas Southwestern Medical Center, Dallas, USA. Her research interests include smart drug delivery systems, nanobiosensors, electrophysiology, and mesoporous materials. She has published more than 235 research articles, published 10 book chapters, also filed 6 patents. And she has been one of the editors in the Journal of Polymers for Advanced Technologies and Secretary of Molecular Imaging Society of India. And she is also one of the expert committee members on nanobiotechnology of Department of Biotechnology. And with this brief introduction, I invite Professor Uma Maheswari to deliver her talk. Yes, ma'am.
Thank you, Dr. Bosco. It is very difficult to refuse Bosco. Our association goes since I think we began our journey at Shastra almost at the same time. And also our research journey also commenced in Shastra almost along same lines. So I think we have been good friends and collaborators, as he mentioned. But I believe that I'm more like an addenda, because we have the galaxy of biosensor people who have been addressing this gathering. And I can always say that I also do some sensor work. And so I'm going to be just introducing you to some glimpses of what we have been trying to do. I hope our screen sharing is going to be fine. Hopefully you're able to see the screen. Is the screen visible?
Yeah.
Is the screen visible? I presume that everything is fine.
Yes, fine. Yes.
Thank you. So I have chosen a particular topic today at the insistence of my good friend, Dr. Bosco, on metabolic syndrome. So I'm going to talk about some of the sensors that have been developed in our group for detecting some markers of this metabolic syndrome. So before going into the sensor part, first we need to know what is the syndrome, metabolic syndrome. So primarily, it is not one particular disease. It is actually a group of risk factors that are primarily arising because of some kind of metabolic disorders. And as a result of these disorders in the metabolism, an individual can develop other diseases which are primarily non-communicable. Some examples are here, like hypertension, diabetes, different forms of diabetes like insulin resistance or high glucose. There can be inflammation that is associated that can lead to other diseases like heart disease and so on, high cholesterol and lipid dysfunction, and of course, obesity. So there can be a lot of complications that can arise as a result of elevation in certain risk factors, and these together are now called as metabolic syndrome or MET-S. Now, this metabolic syndrome has become a dominant feature because of modern lifestyle. We have more sedentary lifestyle, and there are a lot of fast food or junk food culture that is actually made us more prone to these type of risk factors. And the World Health Organization had actually tried to categorize these risk factors. Primarily, these are the major categories in which they believe metabolic syndrome risk factors could be categorized. Of course, the first one would be obesity, that is a body weight. And then comes the glucose dysfunction. So it could be either lack of or loss of insulin sensitivity and development of high glucose, which is a condition which we call as type 2 diabetes. And there can be a dysregulation of the lipid content. So there can be high levels of triglycerides, anything greater than 150 milligram per deciliter, or there could be a reduction in the high density lipoproteins, and there is hypertension, which is also considered as a risk factor for this metabolic syndrome. Now, recently, they have also added more to the list. One of the key aspects is microalbuminuria and the renal failures that are associated with this. So when we have such a wide, varied type of risk factors, developing a sensor, a single sensor, is actually not going to be the answer. We need what is called as an array sensor. But initially, the efforts have always been to look at rapid diagnosis of each individually these type of parameters. So today I'm going to talk about some of our efforts where we had attempted to develop glucose sensors, triglyceride sensors, and a sensor recently that we have developed to look at renal as well as diabetic retinopathy complications. So our approach towards biosensors, I'm sure you have had a wonderful introduction to various types of biosensors by Professor Suri, followed by Professor Joe, who talked about those fluorescent molecules. But our approach has been more on the electrochemical side. So what we try to do is we try to modify the electrodes. We use nanointerfaces. These could be metal oxides primarily, or carbon-based materials that can aid rapid electron transfer. And they also serve as immobilization matrices for our sensing element, which could be enzymes or antibodies, as the case may be. And we use a membrane to retain these biomolecules on the surface of the electrode. So depending on the nature of the biomolecule, we modify the membrane that is being used. And we follow changes in the current to monitor the amount of the analyte of interest in the electrolyte system. So this has been our approach, a more electrochemical based approach. So our research primarily is in identifying the type of interface. And earlier we used only single interface. Now we are moved on to hybrid interfaces, and the kind of capture agent that can be used to effectively and efficiently detect the analyte of interest. So we started in terms of metabolic syndrome. One of our earlier attempts was to create an array sensor, of which one of them was glucose. So glucose, as you all know, is a major energy source of our body. And there are levels, the glucose levels are never constant. It varies depending upon our food intake and physical exercise. And normal glucose, if you are looking at fasting blood glucose, it is said to be below 100 milligrams per deciliter. And if we are pre-diabetic, then it should be between 100 to 125, but any value above 125 milligram per deciliter is considered to be a diabetic individual. So the sensing element that is most widely used is glucose oxidase. And the reason is this is highly selective, the use of an enzyme. But the only complication in getting rapid responses using glucose oxidase is the coenzyme of FAD, or flavin adenine nucleotide, which is actually into the interior of the enzyme. So there can be a reduction, or I could say the electron transfer rate is actually slow between the enzyme and the electrode surface. So most people have tried to circumvent this problem by using nano interfaces. So we had also looked at different type of interfaces and finally came to a combination of carbon nanotubes and graphene. So we used the working electrode as glassy carbon electrode, and we had the reduced graphene oxide and carbon nanotube as a nano interface, on which we had immobilized the glucose oxidase enzyme. The reference electrode used was a silver chloride, and the platinum served as the counter electrode. So we used a simple method of drop casting because we did not want to go with complicated uh, covalent immobilizations that may actually denature the enzyme. So I'm not going to describe too much of these, but what in essence we are trying to show here is that for each modification, you could see there is a significant change in the current that is recorded in the system. So we were looking at the hybrid interface where we had a good charge and a good surface coverage, and we chose this for further studies. We established through the scan rate studies that the reactions are surface controlled. Now this is important. We prefer surface controlled reactions so that we may get more rapid response, and this was established. And we did a series of cyclic voltammetry and amperometry. So for every addition of the analyte in the amperometry, we could see there is a step response indicating that there is a change in the current. And we were able to achieve a detection range for glucose from up to 21 millimolar, which is quite wide range. And the response time was pretty rapid. It was about 3 to 4 seconds. And the stability of these electrodes was close to 80% in the dry conditions and close to 72% in wet conditions over a period of 3 to 4 weeks. So this is the conventional kind of electrochemical nano sensor or a biosensor that we had developed. But the question is, there are so many glucose sensors, and as Professor Suri mentioned, we wanted to know whether the sensor, because it's so fast and we could make it small, can we actually use this for some other applications? So at that time, our group was also working with a lot of cells in terms of cancer therapy. And as Bosco was mentioning, our group does a lot of work primarily for healthcare applications that includes therapy. So we wanted to know if this glucose sensor that we are using could be used for some other purpose also that may be useful for an assay other than just detecting the glucose levels in the blood. So we wanted to look at the cancer cells where the glucose metabolism is slightly different from that of the normal cells. So in the cancer cells, the major source of ATP is glycolysis. So glucose is actually the major source of energy for cancer cells when compared with the normal cells, where we also have the citric acid cycle that is involved in generation of ATP, which is the energy source for the cell. So as a result, cancer cells, they have a high level of increase in these glucose levels, and this is called as a Warburg effect. So we decided that if we are going to monitor this glucose consumption, then we can actually have an idea about this cancer cell proliferation. Now there are other methods by which we actually do this. All the in vitro studies do this a lot. So we wanted to see if our glucose sensor would actually be useful and much more convenient alternate to the conventional methods. So if you're looking at the existing methods for looking at cell proliferation, we have a lot of dye-based assays, which are listed here, the Alamar Blue, the MTT and MTS assays, which are tetrazolium salt-based assays and so on. These actually are based on the presence of an enzyme which are produced in metabolically active cells. So if there is going to be some quiescent cells, then these are not going to be that accurate. And apart from that, these reagents that are added are quite expensive, and we need some incubation time and so on. So it is also, it's not extremely long, but definitely there is more analysis time that is involved. And each of these assay cannot be used for all cell types. There are certain cell types that do not answer well for Alamar blue. There are certain cell types that do not answer well for MTT. So we need to actually use more than one assay to confirm the findings of the proliferation when we use these dye-based assays. Apart from that, there can be variations in the experimental conditions like pH or buffer, incubation temperature, the cell density we use, and so on and so forth. So there is a set of optimization that needs to be done whenever people are trying these type of in vitro studies using these dye-based assays. So what we tried to look was, we did the conventional assay, that is the Alamar blue assay, on a pancreatic cancer cell line. So this is a pancreatic cancer cell line, MAIA-PACA2. And what we did was we incubated different densities, and over a period of time, we wanted to monitor the glucose that has been consumed by these cells using the sensor that we have developed. And then in the same set of cells, we also perform the Alamar blue assay, which is actually an optical assay, a dye-based assay, where we will be able to see the strongly fluorescent rhizoruffin that is actually formed as a result of the enzyme that is present there. So this actually is telling you how the Alamar blue assay, and for the same set of cells, how the glucose utilization is changing. You could see that there is a linear profile that is obtained when we are looking at the glucose measurements, whereas there are quite a lot of fluctuations when we are looking at the Alamar blue assays. So we went on to look at it in a little bit more microns level. We could see that the orange spots are those that are the glucose utilization that we measured using the sensor, and the blue are the Alamar blue assay. So at the early time point, 1 hour, we see there is a lot of deviation between the two assays. Whereas in the later time points, there is actually no variation, they all match. So we wanted to know why these differences are. And the reason is, during the initial period of 1 hour, the cells are adhering, and then they are in a rest phase before they start extending and proliferating. So that is the phase where you see the glucose utilization is actually not there. The proliferation starts after 4 hours, where you could see there is a glucose utilization. So this we were able to monitor here. Now the question is, we have used a dye-based assay as comparison to the glucose utilization to look at the cell proliferation. So the question is, we can also count the cells, using a microscope. So we use what is called as a hemocytometer, where we could actually count the number of cells in each of these grids. So it is actually time consuming, but it actually, you can individually count the cells. And so this is something that most of the cell culture labs use. So we wanted to see whether this glucose utilization is consistent with the numbers that are actually seen by this visual technique. And you could see from the numbers here, the percentage variation is less. It is about, at the maximum variation we were getting was only 13%. So pretty much within that 10% or less than 10% variations we were able to see in the number of cells that we counted visually versus the number of cells that we predicted using the glucose utilization. So all of these were done with the cancer cells. And as I mentioned, hemocytometer is also having several disadvantages, which could be overcome by this very rapid measurement of the glucose using the sensor, because it's less than 4 seconds. And once we had this data, we were encouraged to actually extend this further. So nowadays in cell culture, people are not interested in having a mono layer. They are trying to make tumor mimics where it is a 3-dimensional model. So this is a pictorial picture of how a two-dimensional culture, monolayer culture on a plate looks like. But this is not how cancer is in the body. You will see these type of spheroids that are actually seed, the tumor spheroids. So that is the difference between a 2D and a 3D culture. Now, there are a lot of issues because of the spheroid nature in permeation of the dyes. So to account the number of cells in this is actually little tedious. And so we thought if we can simply use this glucose utilization as an interesting alternate to those dye-based assays to count the number of cells in each spheroid. So we had followed the same methodology we had adopted. So every day, every alternate day, we replace the media, and the replaced media is checked for the amount of glucose that had been consumed by the cells. So we compared the 2D as well as the 3D cultures. And in all of these, we carried out the glucose measurements in the spent media. So this is the data that we have for the glucose utilization and the cell numbers that we have predicted. And we had counted the cells, of course. Even in the spheroid, we disrupted the cells and then we counted those cells to identify the number of cells in those spheroids. And we compared the values that we obtained from the glucose utilization and the number of cells. And again, we find there is a very good correlation. There's only less than 10% variation in this. So if we actually try to look at this sensor, not only is it an accurate measure of glucose from samples, which is actually a marker for metabolic syndrome, we can also use this in the laboratories as a much more convenient dye-free method for counting the number of cells, of course, especially if we are looking at cancer cells. Now, can also be a question as to, okay, you say that your glucose sensor is measuring glucose utilization. How does this compare with the commercial glucometer? Because that also uses glucose oxidase and it is also rapid. So we compared our glucose sensor with the commercial glucometer. And the numbers here, A actually, this A stands for our glucose sensor, which we have made with the carbon interfaces, and B is the commercial glucometer. And you could see there is a very good agreement in the values between these two. So we can use a commercial glucose sensor, we can use our glucose sensor, both of them are very accurate, but the difference is going to be the cost factor. So we would be able to make these much less expensive when compared with those that are available commercially, where the glucose, the strips, the measurement strips are the more expensive version. So to sum up, there have been quite a lot of work on developing nano-interfaced biosensors for glucose, which are based on enzyme glucose oxidase. They are actually seen here. The current work, of course, it is not current. It was done a few years back. Used carbon nanotubes and graphene as the interface. We could see that the detection range is quite wide. And we had, apart from the serum, we were also able to demonstrate that this could also be used as an in vitro tool for people who are cell biologists to actually monitor the proliferation of cells. So this is part one of our attempt towards a metabolic syndrome marker, which also led to another additional application. Now, a part two of our metabolic syndrome markers, it was done by the same student. She had actually worked on these type of metabolic syndrome markers, was on triglycerides. Now, triglycerides are a main constituent of our body fat, and it is this, I could say, is less monitored than cholesterol. So normally people have a tendency to look at cholesterol, but they neglect these triglycerides. But monitoring the triglyceride levels could be an early warning whether we have the risk of developing any metabolic syndrome related disorder or atherosclerosis and so on. So the common triglycerides that are found in our body are the long fatty chain triglycerides. So like we have triolene, and we can have tri-linoline and tristearine. Tristearine is a saturated triglyceride. The other two are the unsaturated triglycerides that are found in our body. But there have been several attempts in literature. Many groups have attempted to make triglyceride sensors, but the model molecule they have used is this, which is actually tributane. So you could see there is a huge difference in the chain length, and as a result, the hydrophobicity and the kind of interactions are all going to be different. So it would make more sense for us to look at triolene or trilinoline, which are more commonly found in our body, to make it more clinically relevant. There are some triolene sensors that are reported. In fact, there is an Indian group by Pundir et al., which has actually been working on different type of nano interfaces, and they have used lipase enzymes for the detection. And apart from that, there have been, at that point of time, very limited sensors that had used these 18 carbon fatty acyl chain containing triglycerides. So in terms of the clinical diagnosis, as I mentioned, any value above 150 milligram per deciliter is considered to be deregulated lipid metabolism. So the risk factor is higher when an individual has more than 200 milligram per deciliter of triglycerides, and they are at extremely high risk if their triglyceride levels shoot above 500 milligram per deciliter. So we set out to identify a set of interfaces that will give us good sensitivity towards the triglycerides. So we had tried a host of nano interfaces. Luckily, we felt we again found the combination of carbon nanotubes and graphene. In this case, it was reduced graphene oxide that was actually showing us better results. Now, the detection of triglycerides actually is a little bit more complex because it doesn't involve a single enzyme as in the case of glucose, but rather we have three enzyme cocktail. So we have to use a lipase, which will hydrolyze this triglycerides to glycerol and the respective fatty acids. And there is a glycerol kinase, which will add a phosphate group to this glycerol. And we have glucose peroxidase, glycerol peroxidase that will convert this glycerol phosphate to diacyl phosphate and the hydrogen peroxide. So this gives us the redox signal. So the triglyceride detection by an enzyme, it is actually an enzyme mix and not a single enzyme. So we need to immobilize all of these enzymes on the surface, and that is actually a big challenge. So we have not gone for covalent immobilization. As I mentioned in my earlier slides, we go for drop casting, and that is what we had done. And we would prefer to have an interface that will promote surface controlled reactions rather than diffusion controlled reactions. So we try to maximize the amount of these enzymes on the surface so that we will be able to achieve good sensitivity. So you could see that when we used the enzyme mix with the carbon nanotube graphene nano interface, you could see there is a drastic increase in the current that is recorded when you compare with the bare glassy carbon electrode. So we used these preliminary data to generate the electrochemical parameters for in the presence of the analyte, that is the triolene. We were happy to note that the reactions are all surface controlled based upon scan rate studies. And we also did the concentration studies. What is shown here is the cyclic voltammogram. We also did the amperometry. And what we could actually see from amperometric measurements is we could actually achieve up to 5.5 millimolar detection range for the triglycerides, and stability which is close to 95% for 3 weeks, and a little more than 3 weeks. So that's good stability both in the dry and the wet condition. And the triglyceride sensor could have a lot of applications in fast detection of the um, triglycerides, trioline. You could see the response time is 1 second. So just like in the case of glucose, we now wanted to see if there can be any additional application for this sensor that we have developed, because it is quite rapid and we were able to detect trioline. So the next question we wanted to know is, can we actually have any additional dimension to this sensor? So again, we looked at cancer cells. There is some, like in the case of carbohydrate metabolism, the cancer cells also have a different way of utilizing lipids. So the distribution of lipids and the type of lipids that are distributed in these cells are quite different from what is seen in normal cells. So I mean, I'm not going to talk a lot of biology, but what people have understood is that the cancer cells, the membrane of these cancer cells have a higher amount of triglycerides. And not only that, there are also vesicles inside these cells that actually store these triglycerides. So the triglycerides, they contribute to fatty acids, and so they are the source, the precursor. So they are actually elevated in the cancer cells. So people have tried to look at this using NMR to see the differences in the triglyceride levels. So as I mentioned, they have detected this on the cells in the lipid bilayer of most of the cancer cells. And they have identified that this is something that happens when a normal cell transforms into cancer cells. So there is also a work where people have identified that obese individuals who have high triglycerides, they have been found to be more prone. I'm talking about men who are obese and have high serum triglycerides. They are more prone to develop prostate cancer. So there is a large kind of an association between the triglyceride levels and cancer. So what we wanted to know was, can we use the sensor that we have developed now, apart from just looking at serum triglyceride levels, can we also use this to monitor triglyceride levels in cancer cells? So what we did was, we took a panel of cells which are normal. So the HT22 are hippocampal cells that are found in the brain, and smooth muscle cells are also normal smooth muscle cells of human origin. And we took two cancer cells. One is a colon cancer cell, and the other one is a pancreatic cancer cell. So this time we chose PanC1. Now, I put these pictures for you to show, see that the normal cells and the cancer cells, their size and shape are highly varied. So what we actually tried to do was, we took these cells and we disrupted the cell membrane, and we measured the amount of triglycerides, the total triglycerides in that medium that is obtained from the disruption of the same number of cells of normal as well as cancerous origin. So here is the concentration of triglycerides that we measured using these cells. And what we could actually see is there are two different zones. You know, the below 2 millimolar triglycerides, we could get, this is a total triglycerides from the normal cells. Whereas the cancerous cells, their levels are higher. So the difference in the triglyceride levels are significant. If it is cancer, we see there is higher amount of triglycerides, whereas if it is normal cells, there is a much lower level of triglycerides. Now, what is significant here is, if you are looking at the smooth muscle cells, they tend to grow very fast. They are highly fast proliferating cells when compared to the brain cells. However, if you are looking at the triglyceride levels, we could see that there is hardly any difference in the amount of triglycerides. Whereas in the cancer cells, you could see that there is no significant difference between the amount of triglyceride. They are higher, much higher when compared to normal cells, but among the cancer cells, there wasn't much difference. So we could actually utilize this in actually delineating normal tissues and cancer tissues, especially during surgery when there is surgical removal of the cancerous tissues. You find that there is actually a confusion as to the tissue, whether that is being removed, especially in the outer layers, whether it is cancerous or normal. Now, this sensor, because it doesn't take a long time in actually measuring triglyceride, the only thing would be the sample prep, and disruption of the cell membrane is actually very easy. You use a lysis buffer, which will actually take less than 5 minutes or 2 minutes. That's something that we could actually look at as an application for the sensor beyond the metabolic sensor marker also. So we have now looked at two markers that we had actually seen in terms of metabolic syndrome, but also we had extended their applications into some cell-based assays. This table actually is a routine table that most of us like to compare how this stands when compared with other kind of sensors. This has this sensor that we developed has a wide range and very good stability. So it has a lot of potential for applications, not just as a metabolic syndrome marker detection unit, but also for distinguishing cancer and normal cells. Now, I think I have enough time for the final phase of my talk, where I'm going to talk about a work that is currently in a device prototype production in level in our lab. So this is actually a collaborative initiative between India and UK. So we have partners, clinical partners in the UK and clinical partners in India who have screened a large amount of population, a diabetic population. Now, diabetic people, diabetes, as I mentioned, is one of the hallmarks of metabolic syndrome. It's one of the outcome. The deregulation of glucose metabolism is one of the risk factors for metabolic syndrome. So obese individuals are more prone to development of insulin resistance and glucose intolerance, leading to elevated levels of glucose, which is what we call as hyperglycemia. And there can also be inflammation and lipid deregulation in them that altogether can result in blocking of blood vessels in the retina of the eye. So these type of blockage of the blood vessels and abnormal growth of blood vessels, because as a result of this blockage, can lead to a condition which is called as diabetic retinopathy. Now, this diabetic retinopathy is actually a vision-threatening condition. It can lead to hemorrhages, it can lead to aneurysms, and the individual loses their vision. It can be unilateral or bilateral. And early detection is important to save the vision. That is very important. So currently, the gold standard for looking at diabetic retinopathy or diagnosing diabetic retinopathy is what is called as fundus imaging. So they image the eye with a very special high resolution camera, use image processing tools to actually identify these irregularities in the vasculature in the eye, and then they come to a conclusion whether the individual has an early stage diabetic retinopathy or is in a more pronounced state, whether it is proliferative type or non-proliferative type, and so on and so forth. So in essence, the diagnosis of diabetic retinopathy is time consuming, requires expensive equipment, and needs the patient to go to a specialized center which contains these facilities in order to get themselves evaluated. Now, in a country like India, where nearly, I don't know whether I can even say numbers because we are not very sure, but at least 60% of the population have either pre-diabetes or diabetes. It is a very large country, and we have many people who have a predisposition to diabetes. It is actually going to be a huge task in trying to get these diagnoses in place for these type of vision-threatening disorders. Not only that, among the various patients who are screened for diabetic retinopathy, uh, they have to be diabetic, obviously, but not all diabetics turn to be having this retinopathy. So about 10% is the hit rate in terms of diabetics. But if we don't diagnose them, then these 10% may lose their vision permanently. So that's the challenge. So the entire project is evolved only to identify markers for this diabetic retinopathy. So one of the marker that was found in both the Indian population as well as the UK population. There are, I'm sure the clinicians would be a better people to address this. But what is known is there are differences depending upon our location and race and origin and so on in terms of our predisposition to diseases. But in this case, for diabetic retinopathy, diabetic population in UK as well as India show a very high level of this cystatin C. Now, the cystatin C is actually a polypeptide. This is a rendering of the polypeptide cystatin C, which has about 120 amino acids. And it has earlier been identified as a biomarker for renal dysfunction. So if you recollect in my earlier stage, when I was talking about metabolic syndrome, I talked about microalbuminuria, which is actually a kind of a renal dysfunction. And any patient who has a renal dysfunction or a kidney problem will also show elevated levels of cystatin C. So now the normal levels of the cystatin C is below 1.05 milligram or close to 1 milligram per liter of our blood. But in patients with diabetic retinopathy, there had been a study, a controlled study in a cohort, where they found all the people who had diabetic retinopathy showed higher levels of cystatin C levels. This was the basis on which we actually started developing the sensor. So as usual, we went with the electrochemical sensing. I'm not going to discuss too much about the usual story. We screened a lot of carbon interfaces, and we came to reduce graphene oxide as a good option for the interface material. And we used an antibody against the cystatin C, which was immobilized on the graphene oxide, the reduced graphene oxide, which was actually functionalized with some amount of COH, and we obtained the sensing layer. So the sensing layer was the antibody that was immobilized, or I would say entrapped on the surface of the reduced graphene oxide interface. Now, we used also a redox mediator to actually capture the signals. We did the cyclic voltammetry, and we also looked at the amperometry. What I've shown here is the cyclic voltammetry. We could see that when there is more amount of cystatin C, there is a decrease in the current that is measured in the system. So we used also impedance measurements in the presence of potassium chloride. And we also tried differential pulse voltammetry for higher sensitivity. So in a nutshell, what we were able to achieve was a sensing range that is from 1 to 10 milligram per liter. Now, this is very much acceptable because any level beyond 1 is considered abnormal, especially 1.12 milligram per liter was a threshold. So this is within the clinically relevant threshold. Now, if we have to do a screening of population, we wanted to have it on a more portable platform. So we made our homemade paper electrodes, which can be easily disposed of. And we studied its characteristics post immobilization of the antibody using SEM and AFM. And we also made, or I would say, in the process of optimizing a microfluidic setup. I don't want to maybe. So this is, we can introduce the sample and along with the buffer, and we would be able to get the response on the laptop. So the entire device could be actually made portable, and so home-to-home monitoring of this would be useful. These are some of the data that we could get from the homemade paper electrodes. And we were able to get a detection limit of 0.2 milligram per liter on this. We also looked at serum, and we looked at the effect of interference. We did not see much of an interference from amino acids, but there was some amount of shift when we had dopamine and ascorbic acid. Now, dopamine is a neurotransmitter that is not expected to be seen in our body fluid. So this probably is not going to be of much of a concern. But ascorbic acid shows an interference. That means there is an elevation in current. So we will have to work with real samples, a lot more real samples, in order to see how this is going to affect the prediction accuracy. So what we actually did, these are our paper electrode and the glassy carbon electrode. So we are getting close to 1.2 picogram per liter sensitivity. We also did some clinical sample analysis of real patient blood samples. So these were obtained from our clinical collaborators. This is a small cohort. I've got 13 samples from them. And these are the predictions. We did it on a blinded way. And later on, they unblinded us when they revealed the results. But when we were making the measurement, the predictions were based on the values that we measured using our sensor. You could see that there is most of the samples that we were predicting based on the values that we obtained from our sensor match with the actual diagnosis of the clinical samples. There were two variants, where they considered these as control samples, but we had reported these to be having diabetic retinopathy. These deviations were because the patients had a kidney disease. So I mentioned to you that cystatin C is also elevated in patients with renal damage. So the overall results that if you see from the real sample analysis is that this is pretty much accurate. We will like to have it 100%, but that perfection probably is, it's just like Carnot engine. But anything even above 80% or 85% is actually going to be a big reduction in the burden in terms of screening, in terms of the cost of screening and the time of waiting. So that we are now currently looking at a larger cohort of 300 patients to test our electrodes, and we are optimizing the final product to be on the portable platform. So we have three different individual attempts as such in terms of metabolic syndrome markers. But this is not going to be the end, because there is no point in having three electrodes separately and trying to get the values. Though when compared with the conventional methods, these have shown promise. What I actually believe is we need an array where we will be able to integrate each of these sensing elements. So in one go, we will be able to get information on the lipid profile, on the glucose profile, or we could even look at other markers like HbA1c, and of course, these type of very specific complication markers like the cystatin C and additional versions. So the future, I believe, is going to be on portable a point of care device which will detect more than one analyte. And for conditions like metabolic syndrome, that is actually the road ahead. And of course, I would like to say this: evolution is nature's way, to push it for even reaching greater heights. And the same is with technology. As we find new things, we continue to grow, and we would push our boundaries further so that we will be achieving even better healthcare. So I would like to acknowledge all the funding agencies which had generously contributed to the research initiatives in our laboratory, not just only on the sensor, but also on a lot of drug delivery and tissue engineering aspects. Thanks to the various arms of the Department of Science and Technology and Nanomission, Department of Biotechnology and Ayush, and specifically for the work on diabetic retinopathy from the Research Council of UK. And I have been benefited by a lot of experience collaborators, starting from Dr. Krishna Kumar Shankara, who has been my collaborator for the eye-related diabetic retinopathy projects, and Santosh from JIPMA, Jayendran, and of course, not to forget Dr. John Bosco Balaguru, Dr. Swaminathan and Brinda from our own university. So I would like to thank all of them. And of course, no thanks is complete without some of the people who actually did the data. And we have a good large group. This is an earlier picture, of us here. But of course, I would like to place my thanks to our Chancellor, Professor Sethuraman, Professor C.N.R. Rao, who has actually been encouraging us through funding and with the guidance in terms of nano, and Professor Swaminathan, who's a good friend, guide, and colleague, who is also the director of the Center for Nanotech, and a whole lot of students, and of course my own girl gang. We have quite a lot of girls in the girl power in the lab, so thanks to all of them. And of course, Nandri and Gamsa Hamnida, I hope I got my pronunciation right. Thank you to the organizers for giving me this opportunity, and all of you for patiently listening through, though what may seem to be a little rudimentary. Thank you all.
Nice presentation. And we have received a couple of questions. I will share the same with you.
Thank you.
The first question is, did you perform the cell culture with the glassy carbon electrode dipped in the cell culture flask or media?
No. So we collected the cell culture media, because the cell culture media would be very less. So we collected the cell culture media and then used it in our QH.
Okay. And as a continuation, also were there studies performed to comment on the effect of applied potential on the cells when you were
because we had not done the measurements directly on the cells. So we only taken the media in which the cells were cultured. So this problem of potential on the cells did not arise. But if we are going to do this with the cells, then yes, we will not be able to use higher potentials. But most of the interfaces that we use are around 0.2 volts or lesser, which would probably not going to alter much. But having said that, it depends on the origin of the cells. There are some cells like the neuronal cells and the cardiac cells which are electroactive. So we don't want to take the chance.
Okay. Was there any significant difference in the current response between the screen printed electrode and the conventional electrode?
Yes, there was. So we could get better sensitivity with some of the screen printed electrodes. The one important factor when we are trying to make these kind of screen printed electrodes, there are other factors like the kind of paper, the thickness of the ink, and the dimensions itself of the working electrode and the immobilization area that we have, that actually contribute to these differences. So with the screen printed electrodes, we can actually play with the dimensions and get one that will be the best. Whereas when we are using the conventional electrodes, we have to work with only the area that is already available. So that that gives us more versatility in trying to get better systems.
And one more question. Hello, no, Professor, could you please comment on how you made the homemade paper electrode?
Okay, so these are all screen printed electrodes. So we use conducting carbon ink. So we created stencils and we designed these dimensions. Of course, we played with the different dimensions, but we designed stencils and we use conducting carbon and silver ink for the reference electrodes. So we use screen printing, a technique called as screen printing. Ideally, you have a stencil, put the ink, and then apply some pressure. So you can do it manually with a squeezy, or you have now automated systems that we have as a screen printing unit where you could do this with more reproducibility.
Thank you. And I think this is the last question. So in terms of conductivity need, the integration of carbon materials are adapted, and why both graphene as well as CNT?
It's a good question. Actually, we had initially started working with only carbon nanotubes. And there was another student who worked with graphene. And at that time, we were only using single interfaces. And it was suggested, what will happen if both of them are mixed? So we actually tried it out. It was more like a trial, and it turned out to be better. So the hybrid interface actually gave us better current responses. So we persisted with that. But you should remember that for diabetic retinopathy cystatin, it didn't work. So we'll have to test it. It depends upon what kind of sensing element we are trying to push into that surface. It may make a difference. So it worked well for glucose. It worked equally well for triglycerides. It didn't work for cystatin, where we had to only stick with graphene. So we'll have to probably play around. I'm sure there are more combinations. If you look at literature, people work with different types of nanomaterials. Our group showed success with these materials, but I wouldn't say these are the only things that probably could work. I mean, there are so many metal oxides. People are looking at organic, inorganic interfaces. Enzene is coming up. So you have a world of possibilities in designing such interfaces.
Great. I think one more question has come, ma'am.
Yes,
in your triglyceride sensor, you had used an array of enzymes. So in such cases, could you explain how surface controlled kinetics was obtained in spite of using multiple enzymes?
So the enzymes were actually, it's actually like a ready mix. It is a cocktail. So it's like a 1:1:1 kind of a ratio. So we just drop casted it, hoping that the response is going to be coming by. Luckily, because we use these nano interfaces, all of these enzymes were sitting only on the surface. We were able to get the response. But it may not be the same for every aspect. So the commercial mix cocktail we had itself was a homogeneous mix of all the three enzymes, so we were able to do it. But if I'm going to do it sequentially, if I'm designing my own system where sequentially I'm going to add, I may probably not get the same kind of a result. That's something that we need to be careful about too.
Great. Yeah, I think that's all the questions from the audience. So once again, I register my thanks, sincere thanks to you for the wonderful presentation and the response to all the questions. Thank you, ma'am. Thank you. Thanks a lot.
Thank you, sir. Thank you. Thank you very much.
Thank you very much.
Thank you very much.
I should say Gamsa Nida.
So I actually have a quick question. So
Sure.
is it possible?
Yes,
Yeah,
sir.
sure.